Okay, so I think when you and I were talking beforehand about this, we did want to sort of give everybody, including ourselves, I think, a break from slides and make it a bit more conversational. But I think what we want to cover in this session really is, I suppose, why public and patient involvement is important, and I think important in social research and in research that uses routine data, and also what are the problems about doing that, what are the barriers, and then I think you're going to talk a bit about how you'd actually do it, how you do training, and you're going to give us a couple of examples of that, and then we're just going to have a sort of takeaway or key messages. So does that sound okay?
Yep.
Okay, so I'm going to kick us off first with why I think it's important. I think I need to state first of all that anything I say is my own opinion and doesn't really say anything about HDR UK's opinion or their views. My take on this is that this is really a matter of rights. I think it's about nothing about me without me. It's about ethics. It's about my expectations as a citizen. It's about social inclusion. It's about human rights, about privacy. It's about rights to family life. And those are all grand, big, ambitious, overarching sentiments, but I think we ignore them at our peril. And they're really the foundation, I think, to build on a sound basis, to build trustworthy and transparent systems that people can have faith in and feel that they can rely on. And that's not just in social research, but I do think it's really extra important in social research, because social research is about how our society is organised and how it's designed. And I think there's even stronger ethical reasons why people have to be involved in that. I don't think you can exclude anyone from that, really, regardless of where they live. You know, if they live independently in the community, that's fine. If they don't live independently in the community, they're still citizens, they still have rights. And I think that we have to remember that. I think there's also an issue of power and what gets recorded, what's not recorded, what are the gaps, why is that data missing, who decided it wasn't important enough to get recorded, who decided it was important enough to get recorded. So those are sort of power questions, and they feed into, I think, issues of equity and fairness and justice, and we can't answer those questions without involving people. I think there's a real value. We were talking about it earlier about the role of evaluation in improving services, and where the public are, you know, we're paying for these services either directly or indirectly. So through taxation, and for a lot of social care, a lot of that cost falls on private individuals. There is a responsibility to allow people to explore the data and the rationale for why things are the way they are. And one last thing I want to say about this is that every data point is an event that's meaningful for an individual and for somebody who cares for that individual, cares about that individual. What we're talking about here is routine data. It's not necessarily routine for the individual. We mean routinely collected. Those events can be the highs and lows of an individual's life. And I think it's really important that we do remember that. So I'm going to hand over to you and you can tell me what you think about that.
Thanks, Debbie. I totally agree with everything you've said. I also think this is one of those areas where doing ethically the right thing, as you've described, and also doing what improves the quality of the research are actually the same thing. And I use a little bit of a metaphor to explain this, but I think it's really important. We have to have the perspective of the academics, we have to have the perspective of the people who deliver care in there, but we need the perspective of patients and publics and people who use these services. And I use the metaphor of a train journey. You can imagine a train traveling around the side of a mountain, and below the mountain is a valley. Some people on that train will look out of one side of that train and see that side of the mountain. Others looking out the other side will see a valley. Some people are travelling forwards and some people are travelling backwards, depending on how they sat on the train. Each person's got a very different perspective on that journey. You can't say one perspective is more valid than the other, but you can say in order to understand the whole problem, you need all those perspectives. And I think that's where it's really important to have public involvement in research, because we often miss that perspective. And I think that potentially leads to less valid and less useful research. And I think if we want to have research that's going to benefit individuals who use services and society as a whole, then having the public involvement perspective in that is really important. It helps us to understand the context to a problem. And once we understand the full context of the problem, then it may change what we think are the main aims and objectives of our work. I think it also helps us then in defining acceptable solutions and options. And if there are options with drawbacks, how we work with members of the public to address those things. I also think it helps to validate our work, to make sure that it makes sense from a real world perspective. So I think the ethical things that you've outlined are really, really important, but I actually think in this case, they also complement very much what contributes to good, valid and usable research in this area. But I think the next topic we're going to, I should say some more about that, Debbie, but also we're going to talk a little bit, if it's so good, what's the problem? You know, what are the barriers?
I don't think anybody in research feels that it's impossible. I think a lot of people feel that it's very difficult. And a lot of those constraints are practical. It's about time and money and the upfront investment required in both of those fields. You need a lot of time. You do need to put the legwork in to sit down and talk with people and understand where they're coming from. We were talking earlier about the problems within how data is stored, and that's even, you know, at the minute, I think so far this morning we've really focused on data in England, and I think with my HDR UK hat on, I would say that I want to see a UK-wide approach to this, because we can learn from what's happening in Scotland and what's happening in Northern Ireland or Wales just as much as we can from England. So I think that's something really important to remember. Coming back to where the difficulties are, I think there's the language we use and that we can fall into very easily, and we use acronyms and, like, you know, even the word data is difficult. It's off-putting for a lot of people. And we need to find ways of talking that are inclusive and that are grounded in everyday terms. And we need to make this much more normal and much more usual, and not elite, not something that requires people to have higher level education to take part in. Because there are differences in the way social care is organised across the UK, there's also differences that need to be explained to researchers, because I think a lot of researchers don't understand why things are different across the UK, and that context needs to be discussed and brought out into the open. And I think going back to what you were saying about evaluating services, you're absolutely right in terms of service evaluation and improving service delivery. That PPI role is critical in identifying what the priorities should be. And I think even explaining it or expressing it helps bottom out some of the issues that we assume that we all understand and we don't all necessarily have the same view on. So that's my view on that one. What's your thinking about the barriers?
I totally agree with you, and I think the jargon and developing shared language between people who are doing the analysis of this kind of routine data and members of the public is really important. There's a general issue about jargon, but in particular in this area of work where you get people beginning to talk about things like regression, discontinuity analysis and so on, this becomes a bit of a barrier. Yeah. And it's not just actually a barrier for patients and members of the public, it's a barrier to people who run the services. So one of the points I'd like to make is I actually think if you work out how to do this language for the patients and members of the public, you're actually doing it for the people who are meant to benefit
Yeah.
from this research who are running service. And actually, quite often, behind the jargon is a relatively simple concept that you can get over to people. You don't need to explain all the technical issues, but you can explain. And in a minute, I'll give a couple of examples of where we've done that, I think, quite successfully. I think the other barrier here is that people feel that they're not clear about what patient and public involvement will add. So they can see that it's a good thing to do, or it's something that you're meant to do, but actually not really appreciating how it's going to add value to the research. And I'm going to say something a little bit about that in a couple of examples I'm going to give. And I also think sometimes people have concerns about how public contributors are selected and who they are and how representative they are of the population. And there is an issue there, I think, for the public involvement community to address about making sure that the voices that we work with are more diverse and represent a range of backgrounds. But in particular, just coming back to the jargon thing, one of the things I wanted to talk about is some training that we've developed for public contributors, really to help overcome some of these barriers and create a shared language. So I've been working with a colleague named John Kellis to develop some training to support public contributors, and it has 4 elements to it. So the first topic that's covered is the uses of individual data and how that's collected and used for research. The second module is about the uses of service level data and how that's used. The third looks at various apps and things that people now have on the phones and so on that are collecting data. And the final one, which is slightly outside of this meeting's rim, but I think it's going to become increasingly important, it's artificial intelligence and diagnosis and so on. And what we've done with that training is created short videos from experts in those areas. And actually, Rich Wood, who was on at the beginning of this session, is one of those people who we're very pleased that Richard did a short video on the kind of work he does. And the training is based on short 15-minute talks that introduce the key ideas and then used to stimulate a discussion with members of the public. And it's worked really well. We've kind of created a group of what I call digital critical friends, who are familiar with the ideas and the concepts that underlie this work, and therefore can meaningfully engage with it quite quickly. And that's been really successful. And interesting, when we advertise that research, that training, we got lots of people who are not public contributors, but people who are involved in service delivery who said, I really need to come on that course. So what we're developing now is a model where it's patients and members of the public learning with other people about the uses of routine collected data and how we can all learn to understand what the implications of this work is and its benefits and some of its pitfalls. I mean, what some of the issues we also do is explore some of the ethical issues in that training, some of the issues about working with the private sector and the benefits of that, but also some of the potential issues that need to be explored with that. So that's a resource that we've developed, and we're very happy to share that with other people if people want to make more use of that. Debbie, I don't know if you want to add anything to that, because I know you've been doing some similar work.
Yeah, well, in HDR UK, we are trying to approach training, but in a way it doesn't really call it training. It's hard to get away. It's hard to get away from it, but I think it's important that it's seen as something that everybody can do and everybody can be involved in. And it's really important, I think, for not just with HDR UK, I'm also involved in another group called Use My Data. And it's about really just making this ideally part of citizenship, part of who we are. And in an ideal world, I'd love to see this as something that's discussed in early years in school, and what all this means, and realize we're a bit away from that, but it's about making the information accessible and making sure that the people who don't know what they don't know,
yeah,
and that's really the issue, that there's some way of making all this, and you're talking about AI, and that's that's just another world for most people, but it's not. It is part of their world, but actually thinking about it and talking about it and having a frame of reference or some understanding of it is really important to who we are. So it's the work that we want to do is to make it as easy as possible and make it sort of reduce those barriers. And all of the things about having sort of chats rather than text-based stuff and actually just having conversations helps with that. And just the underlying idea of literacy and health literacy and digital literacy, that is going to become more important everywhere. And I think it's something that we're starting to tackle, but I don't know when the tipping point will be. And I think we're probably a little bit on the back foot, but I think we are making a start on it. What can you give me you had talked about a couple of examples that you've been working on.
Yes, I'll give those examples. And interesting about the tipping point, because actually it's funny, isn't it? One of the things about the COVID crisis is that 12 months ago, no one would have known what R meant, and no one would have looked at those graphs about figures and things. And now the whole population is a lot more aware of it. So I think obviously it's a particular thing that's happened over the last 12 months, but I think people are a lot more and will continue to be a lot more aware of all this and want to know what's happening. But yes, I've got a couple of examples. Fortunately, my examples are from healthcare rather than social care, because that's the stuff I've been doing. But I think the principles are the same, and both of them involve using routine collected data from services for research purposes, and how we work with members of the public to develop that work with some big benefits. So the first one I want to talk about is a project that I was part of, where we were looking at the benefits of placing a GP in an emergency department. So does that really take the work pressure off of the ED staff, emergency duty staff, because of people that are inappropriately turning up there and could be seen by a GP? So just putting a GP in that department help alleviate the problem. And the routine data we collected was HES data, health statistics data that's routinely collected. So we were using routine collected data on things like waiting times, meeting the 4-hour target, hospital admissions, and also things like reattendance at A&E within a relatively short period of time. So we collected that data and we compared places that had got a GP on, or times when a GP was on, compared to times when GPs weren't available, or in a department where there wasn't a GP. And we had a quantitative team who did some regression discontinuity analysis on that, I seem to recall, and produced lots of lovely forest plots for us. But what we did was we presented this data to the patients and the members of the public, said, what do you think this data means? And we did a little bit of training. We explained how to read a forest plot, and it's not that hard, and it was relatively easy to do. And the quant team that we were working with were really supportive and really helpful. And we presented the data to the members of the public. Actually, what turned out to be the case was, after you'd put your GP in, there was very little improvement in any of those outcomes, and especially when you'd allowed for any confounding factors. So the public contributors asked a number of questions just to check that they'd understood the data correctly, and the quant team did a good job of answering it even-handedly. They came to the conclusion that this was quite an expensive thing to do, putting a GP into an ED department, a lot of reorganisation, putting in structures to support it and so on, very little benefit. And also they were concerned about the impact on the shortage of GPs already in primary care. So they basically came in and said, we don't think, as patients and members of the public, having looked at the data you've collected and interpreted, we don't think this is a good idea. This is a bad idea. And they were really able to say that very clearly and very powerfully in a way that other people were hesitant to do, not least because a lot of hospitals have already done this. But that particular role, I think, was really good, because they saw the picture, and it was a little bit like it's kind of a king's new clothes role. They just sat there and said, look, this is not working, folks. And having people who aren't already bought into things, either because of an academic career or interest or part of the system in delivery care, is really important and really powerful. And that was a really powerful thing. The other thing I wanted to just talk about very quickly was a project I was involved in, where we looked at the reorganisation of neonatal care, and particularly neonatal care for very premature babies, which are relatively rare. So there's a benefit in centralising those services because basically you centralize the specialist equipment, and also you build up the expertise, so you get better health outcomes. But there's a consequence in that in terms of families having to travel further. It's worth noting that you got high rates of very premature babies among people on lower incomes. So there's an issue of the impact on the families and the distress, which was very important context stuff to understand. But also the parents pointed out that they were, perhaps understandably, would travel further to a centralized unit if they thought it was going to improve the survival chances of their child. But what they weren't happy about was if that child was not able to transfer back to a local service, not because of clinical need, but because of blockages in the system. And they raised this as a significant problem. So we built into the model, which something wasn't there before, which was to collect data on how much of the delays in discharge to local services were due to blockages in the system as opposed to a clinical need. That's something that hadn't been thought out by the modelers in the first place and was built into the model. Actually turned out to be something that the parents wanted, but was also very useful to the people managing the system. But we wouldn't have got that insight from that if it wasn't for their contribution. The other thing that they did was the modelers, when they looked at different reorganization scenarios of the service, assumed that people would travel by car, when in fact a lot of people would be using public transport. So again, they reorganized how they modeled it. And interestingly, we were able to really work well with visualization data techniques to show how we could get to a nice tipping point, sweet point, as it were, between these negative consequences and the positive consequences, and then move forward in terms of recommendations for what might happen next. And also it was very valuable for health economists, because we could look at some of the disadvantages for people, particularly on lower incomes, and build that into our analysis based on our work with the parents. So in both those cases, we were looking at routine data, we were looking at quite sophisticated statistical analysis and modeling techniques and so on. So all the things that we've just talked about in terms of barriers, but actually in both cases, the patient and public involvement was really crucial, I think, in improving the quality and the validity and usefulness of that research.
Yeah, I think that's absolutely right. Sorry, I interrupted you.
No, it's fine. I was going to say I'm aware of the time. So I think we were just going to finish off with a couple of maybe key take-home messages. So Debbie, I don't know if you want to say anything at this point.
Oh, mine's really straightforward. Just do it. It's the right thing to do. It uncovers so much. I think there are so many benefits. I appreciate that it takes time and it takes resource up front, and I think I think for researchers, if they haven't done it before, it can feel like a huge challenge, because it's about learning a different way of speaking and a different way of thinking about your own research as well, I think. But I would just say do it. That's what my take-home message. So what's yours?
Well, mine is actually, I'm going to quote a researcher which wasn't this particular area of research, but it was a similarly technical area of research, preclinical drug development. And he'd said he said, I did it because I had to do it and I was skeptical. But now I've done it, I've been really surprised about how useful it is. So his message was approach an open mind and be surprised by how beneficial it can be. So my take-home message is the quote from that particular researcher.